So my topic is about left bundle branch block. Okay, I'll be start with case discussion first lah. So in the early morning, when there's raining, okay, 64 years old female with underlying asthma, hypertension, dyslipidemia, come to ED with complaint of SOB. So the vitals taken, BP is 200 over 130, and then tachycardic 150, tachypneic, SpO2 drop 68%, temperature is 37. So there's a raised GVP and also pedal edema. On auscultation, there's a general crepitation and there's a galloping rhythm. So you make the ECG. The ECG shows that, okay, this is the ECG. So any takers wants to tell me what's the abnormality about this ECG? Anyone? Any takers?
Boleh sebut nama yang dekat participant tu.
Okay, siapa kat sini ya? Saleh. SD23. Saleh, nak try? Tak apa, dia tak ada betul salah. Okay, tak ada ni. Just mungkin jawapan tu salah je lah. Okay, boleh try tapi mungkin jawapan tu salah lah. Okay, anyone? Zaim ke? Nurini? Okay, we'll discuss this case. It's okay. You can try.
Saya minta Abang Desmond lah untuk bagi pendapat tentang ECG ni. Desmond. Hello Desmond.
Hello, Dr. Desmond. You want to try? Would you like to try? What is the ECG finding for this patient?
Hi Desmond. Semua orang senyap ni. Faiza, boleh? Faiza? Ke dia orang masuk tapi silent?
Tak apa, tak apa. Okay. Tak ada orang? Tak ada respon? Dah panggil dah?
Suhaila ada respon.
So, tak nampak ada Suhaila ya. Okay, Suhaila. Boleh Suhaila? Dia related to this topic lah. Tak lari jauh pun. Kalau nak describe the ECG.
ECG shows Lbbb. Silence Lbbb. Tapi tak berapa nampak sangat. Is it dia punya positif discordant tu lebih 5 smallpox tak?
Any participant would like to try?
Suhaila, kau kata Lbbb kan? So with this presentation Lbbb ni adakah kita perlu worry ke tidak?
Yalah, kalau tengok ni kita kena tengok modified Scabosa lah. Tak nampak sangat lah. Kena kira the S ratio. Kalau more than 25% kan, baru kita rasa dia positif Scabosa, dan kita kena worry lah.
Later will be discussed about this Scabosa. Okay. Okay. Any other takers? But I think I just proceed. The ECG finding. Okay. So. Okay, tadi 64 years old, datang complaint of SOB and BP is high. So this is the ECG lah. So basically this ECG it shows that the axis is normal. The QRS is broader lah, more than 120. Lepas tu dia ada broad notch arwah dekat bicep lah. So this is the typical of Lbbb. Okay, regarding the Scabosa, tak apa, I just calculate for you guys first. Okay, so the concordant dengan concordant ST elevation and depression, there is no, and just present with discordant lah. Okay, ada dekat V4, V1 to V4. So this one is not fulfill the Scabosa criteria lah. Okay, tak apa, this one I will be discuss later. So you done some bedside echo. Bedside echo shows that there's a good left.
Adit, suara kau tenggelam. Boleh kuatkan sikit suara. Ada mic cabut ke apa ke?
Dengar tak? Okay, so the bedside echo shows that there's the good left ventricular function. There's no regional wall abnormality and no ventricular hypertrophy. We proceed with lung scan. There's a multiple B line lah over bilateral lungs. So we start the initial treatment. Okay, we started on this patient with an IV and IV nitroglycerin. So this is the X-ray of the patient. So basically dia ada upper lobe diversion, the bad wing appearance and also cardiomegaly. So for the pandemic things, regarding COVID things tu tak apa, kita tolak tepi dulu. Okay, sebab kalau sekarang we will be suspect more on COVID lah. Okay, tapi kalau untuk this presentation we just focus on what I want to present. Okay, so the question is, are we going to treat this patient as STEMI or not? Okay, any takers want to answer this? If STEMI, why? Kalau non-STEMI, why? I mean ACS, why? Anyone? Okay, Sofina, nak try ke?
Basically to reformulate lah. So basically this patient came in with SOB, high BP and Lbbb ECG not fulfilling Scabosa criteria. So the differential is broad. Patient had asthma, maybe it's asthma, but X-ray doesn't show it's asthmatic picture. About COVID patient doesn't came to you sudden onset SOB, you should take a long time. Temperature also doesn't have. So what do you think? Do you think this patient Lbbb with heart failure or this is patient with ACS or non-STEMI or STEMI, and why? Zaim nak jawab tak? Zaim?
Zaim, ada Zaim.
Kalau Zaim malam-malam patient datang macam ni, apa Zaim nak buat? You want to activate cardio ataupun nak thrombolyze? Ataupun you just continue je dengan the treatment?
Anyone? Ataupun okay, Sohaila again lah. Sohaila je yang boleh respon kan. Jamilah ke? Oh, Khalil? Are you going to activate apa ni? PCI ataupun tak lah? That's the question lah. Patient datang SOB in failure and then ada Lbbb. ada yang type ke? Dapat. Okay, okay, kalau tak ada tak apa. I'll post it first. Okay, that's the dilemma lah. Are we going to treat this patient as STEMI or not? Okay, so 1 hour later, the patient able to wean off the NIV and change to nasoprom. So the ABG is acceptable, and then the result come back with drop is high, and then we started on dapat antiplatelet and low molecular weight heparin started. So we refer this team to cardio team lah as APO, jadi to non-STEMI and hypertensive emergency lah. Okay. Okay, that is the question. Okay, would you like to activate PCI or thrombolyze this patient, ataupun we just start on medical therapy and also give early elective angiogram? Okay, that's the question. So this is just a brief about left bundle branch block. What we know about left bundle branch block is when there's dekat ECG, ada abnormal electrical activity lah. I mean dekat heart ada electrical activity, and then it will show dekat our punya ECG lah. Most often in underlying heart disease can be asymptomatic in patient yang structurally normal heart lah. Orang yang normal heart pun boleh dapat Lbbb. Okay, okay, this is just the epidemiology. The prevalence of the Lbbb increase with age. It means that the older the patient gets, the higher the epidemiology lah. Okay, there's a study done to 237 of people. They only found out that there's about 0.05% case of Lbbb in young age. So it means that it is infrequent in young healthy subjects. So okay, and then another study shows that okay, the bundle branch block is correlated strongly to age lah. Means the higher the age, the stronger prevalent dia untuk dapat Lbbb. Okay, the etiology, it can be structural and also functional. So Lbbb is a slowly progressive degenerative disease that involving the conduction system, and any cause that contribute to myocardial fibrosis can lead to Lbbb lah. For the functional, maybe there's a ventricular tachycardia and also hyperkalemia lah. This one, why? Because it can depress the conduction in his Perkongsian system. Okay. So this is the anatomy for Lbbb. Okay, we know that the electrical conductivity from the heart is started from SA node, and then it travels to AV nodes, and then it will branch dekat left and right lah. So dekat left component of bundle branch, there ada another 4 branch, okay, which is the pre-divisional segment, anterior vesicle, posterior vesicle, middle septum vesicle. Okay, this is the anatomy. That's the anatomy. I think everybody knows about this. So for the electrophysiology, how the conduction is occur in the heart. Basically, in normal conduction, as I said, started at SA node, and then it travel down to the bundle sheaths, and then they akan separate to left and also right bundle branch. So basically, the conduction tu dia akan start dekat SA node lah. So dia travel down. Dalam Lbbb ni dia ada conduction delay, means that the impulse dia akan travel first to the right bundle branch, and then baru dia travel to the left lah. Basically dia nak cakap ada vector yang alteration lah. Okay, depolarization vector, sorry. Okay, it's okay, tak apa. I'll show you the video how the conduction over the heart later. Okay. Okay, this is how the bundle branch happen. It's a short video.
Bundle branch blocks happen when there is an obstruction in one of the bundle branches, left bundle branch block and right bundle branch block inside that is affected. In the normal heart, the two ventricles are depolarized simultaneously by the two bundles and contract at the same time. In bundle branch blocks, the unaffected ventricle depolarizes first. Electrical impulses then move through the myocardium to the other side. This results in delayed and slow depolarization of the affected ventricle, hence a broader QRS complex, typically longer than 120 milliseconds, and a loss in ventricular synchrony. Left and right bundle branch blocks are diagnosed and differentiated by looking at ECG recordings obtained from the chest leads, which register signal movements in a horizontal plane. Of these, the most useful are leads V1 and V6, and they are best located to detect impulses moving between the left and right ventricles. Activation of the ventricle starts with the interventricular septum. In normal conduction, depolarization of the septum is initiated from the left bundle going to the right, toward V1 and away from V6. This results in a small positive deflection in V1 and a negative deflection in V6. The signals then move both directions to the two ventricles, but as the left ventricle is usually much larger, the net movement is to the left, away from V1 toward V6. This corresponds to a negative wave in V1 and a positive wave in V6. In the right bundle branch block, the initial septal activation is unchanged. The left ventricle depolarizes normally toward V6, away from V1, producing a positive deflection in V6, negative in V1. The impulses then reverse the direction, spreading to the right ventricle, hence a subsequent negative wave in V6, positive in V1. Lead V1 gives a characteristic M shape with a terminal R wave, while V6 is a broader S wave. In left bundle branch block, septal depolarization is reversed from right to left, giving a negative wave in V1. The right ventricle activates first, with the signals moving to the right, generating a small upward deflection. Depolarization then spreads to the larger left ventricle, resulting in a large downward deflection. V6, the opposite, producing a wide, characteristic bunny ears QRS complex with two R waves. Polarization is reversed from right to left, giving a negative wave V1. The right ventricle activates first, with the signals moving to the right, generating a small upward deflection. Depolarization then spreads to the larger left ventricle, resulting in a large downward deflection. V6, the opposite, producing a wide, characteristic bunny ears QRS complex with two R waves. In some cases, right ventricular depolarization may not be visible. Some people with bundle branch blocks are born with this condition. They usually do not have any symptoms and do not require treatments. Others acquire it as a consequence of another heart disease. These patients need monitoring, and in severe cases, a pacemaker may be required to restore ventricular synchrony. Treatment is indicated. In type 2 second.
Okay, that is how Lbbb happen lah. Okay, because there's a alteration dalam electrophysiology. So for the ECG criteria, okay, as mentioned dalam the short video, so the QRS complex duration is more than 120. Okay, they will be dominant S wave in V1. Okay, because of the alteration tadi lah. Okay, they are the broad monophasic R wave in lateral leads, and also they are the absence of Q wave lah in lateral lead. Okay, dia ada prolonged R wave lah. Okay, dia punya kriteria ni okay varies from one patient to another patient lah. Okay, and another associated features including there's a left axis deviation and poor R-wave progression in the precordial leads, and also there's the appropriate discordant lah. Okay, tak apa, yang ni regarding the Scabosa criteria lah. Okay, so this is the typical one yang for Lbbb. Okay, there's a W shape dekat V1 and also M shape dekat V6 lah. Last time we always remember this as William, W, L, M. So L mean the Lbbb. So why, how to detect infarction in Lbbb? Okay, this is the challenge because it present a unique diagnostic and also therapeutic challenge to the clinician. Why? Because in Lbbb, the characteristic of ECG changes caused by the alteration of the ventricular depolarization. Thus, the left ventricle activation is delayed in Lbbb, and the initial septum activation is from the right to the left lah, opposite the normal situation. Thus, in Lbbb, the septal Q wave indicative of MI are absent. So that's why it's hard to detect infarction in Lbbb. So in 1996, okay, the Scabosa criteria is made by one physician named Elena. So Dr. Elena ni dia bagi kita guide how to diagnose infarction in Lbbb lah. So that's the starting off of the Scabosa criteria. Okay, the Scabosa criteria I will explain later. And then in 2012, if I'm not mistaken, okay, the modified Scabosa ni ataupun nama lain dia is Smith modified Scabosa. Is Dr. Smith ni dia revise balik the Scabosa criteria. Okay, the only different there's a different in Scabosa criteria and also the modified criteria, which is the last is the third one lah, yang discordant tu. Why? I will explain to you after this lah. Okay, okay, this is the original Scabosa made by Dr. Elena. Okay, so we can see dekat yang grey area tu, there's a normal Lbbb lah. Okay, as I said dalam earlier slide, the criteria for the Lbbb is normally dia akan ada broad QRS, and then dia ada S wave lah dekat dekat V1. Okay, you can see dekat yang bawah ni. Okay, so what happened in ischemic Lbbb? Okay, kita nampak dia ada alteration, ada ST elevation lah. Okay, how to calculate? Okay, so you can see dekat, for example, okay, the first criteria in Scabosa criteria, Scabosa ni dia nak cakap ST elevation dekat concordant ST elevation. What does it mean? It means that there is a positive QRS. Okay, you can see here positive QRS. Okay, normal Lbbb dia akan ada S wave lah. So dalam ischemic ni dia akan ada ST elevation dekat lead, mainly dekat V4 to V6 AVL and also lead 1. So you can see that there's a ST elevation dalam concordant lah, the first one, untuk dapatkan 5 point tu. Okay, so in point nombor 2 is dia nak cakap ada concordant ST elevation. Okay, mainly dekat lead V1 to V3. What does it mean? Okay, sama, there's a negative QRS complex. Okay, we take the isoelectric line. Okay, you can see the punya depression tu follow the negative QRS. Okay, that it means by concordant ST depression.
So basically, kalau QRS tu nampak lead ke atas kan, so dia will follow with the ST depression normal. Kalau di atas dan atas, itu adalah concordant. Normal macam Lbbb, LVH juga kalau macam QRS tu tall R wave, dia akan ada ST depression, it is normal. Tapi kalau dia ada ST elevation on top of the tall R, so basically it's abnormal. Faham tak? Itu yang discordant is normal, concordant is abnormal.
Okay, so this is how we differentiate between normal Lbbb and also ischemic Lbbb lah. Okay, so this is the original Scabosa criteria lah. Okay, so okay, the Scabosa criteria ni it will give you the specificity 98%, but the sensitivity is less lah, basically about 20%. What is the difference between original and also modified Scabosa criteria ni? Besides dia punya what we call it, dia punya scoring tu, okay, the modified Scabosa criteria ni dia improve the sensitivity lah. Tadi yang original is about 20% dia punya sensitivity, but in Scabosa modified Scabosa dia improve to 91%, but this specificity is a bit reduced lah. Okay, okay, that's the difference lah. So in the modified Scabosa criteria, okay, if you see dekat dia punya concordant, dia tak ubah apa-apa. Okay, the ST elevation and also the ST depression ni dia sama je lah. Dia punya how we look at it, it's just that the discordant ni, okay, dia just nak we measure. Okay, how we measure is how much the height of the discordant ST elevation in compare to the negative QRS lah. So kalau kita score, kalau yang dalam original dia bagi fix amount dekat discordant ni, dia nak more than 5 mm. Tapi kalau dalam modified Scabosa ni, kita regardless dia punya dia tak bagi fix lah the numbers, dia just nak kita kira the ratio. So means let's say kalau kita tengok dekat atas ni ada let's say 3 boxes, dekat bawah ni 10 boxes, like the ratio is more than 30, the ratio is 30%. Okay, means the lead is positive lah. Maksudnya kita bagi score dia dua. Kalau let's say dia tak fulfill the 25%, okay, kita boleh kita nak cakap benda tu is less significant. Okay, this is the guideline last time lah. Last time kita consider the Lbbb or new Lbbb is considered semi-equivalent and is a part of the criteria for thrombolysis. Okay, this one just according to the American Cardiology guideline in 2004. But recently dia nak cakap okay, it just nak bagi tahu kat kita, okay, tak semua Lbbb tu akan ada occlusion. Okay, this is based on the study done lah. Ada 4 study. They want to say to us that the percentage of occlusion in Lbbb is only 40% lah. Out of the 225 subject, okay, there's only 89 people yang ada Lbbb plus the occlusion. Okay, that's why dia cakap not all Lbbb akan ada occlusion. Okay, this is how we approach patient with Lbbb lah. Okay, we suspect MI and also an Lbbb. Is it new or old? Okay, kalau the patient is having hemodynamically unstable ataupun acute heart failure, okay, the guideline, the algorithm is kita is advisable to for PCI lah basically, and also PCI or fibrinolysis. Okay, let's say kalau patient tu is stable, kita akan calculate the Scabosa criteria lah. Okay, let's say the Scabosa criteria is not fulfilled, still it doesn't rule out occlusion in Lbbb, okay, we need to further testing this patient with echocardiography and also serial biomarker testing lah. Let's say the finding is more suggestive for occlusion, okay, in the end memang kita nak PCI lah basically. Okay, kalau let's say Scabosa is fulfilled and dia punya diagnosis is semi-equivalent lah, which is the punya final outcome is for PCI or fibrinolysis. Okay, how about echo in Lbbb? Basically echo plays a critical role. Okay, this one I cannot find any literature regarding echo finding in Lbbb, but echo still plays a critical role in early detecting regional wall motion abnormality in area of culprit coronary supply. In bundle branch block, the causes of abnormality in sequence activation wall, contraction and relaxation might be considered false positive lah. Let's say, but kalau dalam echo ni, kalau let's say the echo finding is kita nampak any abnormality, okay, the troponin is the serial biomarker is high, so it more suggestive of occlusion lah in Lbbb. Okay, the case continues. Okay, the patient done coros, so there is a stenosis dekat LAT, basically 60 to 70%, and stented was inserted lah. So the patient initially we diagnosed as myocardial infarction with non-obstructive coronary artery, but kita revise the patient is revised to ischemic Lbbb with decompensated CCF. Okay, this is the finding of the echo.
Tunjuk balik echo. So Adib, what can you see with this echo?
Okay, dekat echo ni dia nak cakap ada delay in septal punya contraction lah. That's what I can see lah. For further detail dia.
So basically, the contraction start at B5 tu, AS, AL, lepas tu nampak dia macam berjalan. So normally the LV will contract together with the RV kan. Tapi yang ni nampak contraction dia lebih kepada progression. Tengok satu lagi. Apa? View. Kalau macam ni cuba tengok.
Ini you can see that the movement of the electrical tu nampak macam ada lambat lah. Yes.
That's why there's a false positive RWMA. You tengok ni macam apa ni? Macam contraction tak sama kan? Then you akan cakap oh ni regional wall hypokinesia. Then you diagnose as ACS ataupun STEMI lah. Faham tak? So yang dia kata tadi false positive kalau you buat echo.
Tapi itulah in our practice it might be hard to see this kalau kita tak familiar. For me kalau saya yang tengok, kalau buat echo mungkin tak dapat nak detect. Okay, sangatlah. Okay, mungkin kalau ada orang yang lebih
kalau Lbbb ni kiranya dia right ventricular track tu dia kira macam flow pada right ventricle punya track tu yang rosak kan, so dia pergi belah kiri dulu kan.
Lbbb left branch yang rosak.
Yalah left branch yang rosak kan. Tapi so ventricle mana yang akan ni dulu?
So boleh jawab Adib.
So kalau dalam Lbbb ni, in normal conduction dia akan start dekat left, dia akan travel, dia akan start dengan left dulu, and then baru dia akan travel semua. Tapi sebab ada, kalau dalam Lbbb ni dia ada block, dia ada nama pun bundle branch block dekat left side. So dia akan impulse tu dia tak travel left side first, tapi dia akan travel right, baru dia akan bagi dia punya action potential tu towards left side lah. So dia ada delay.
Tapi tadi Syed, kau cakap apa yang left ventricle tu macam dia dah apa nama dia? Kalau ke echo ni contraction tu dari left ventricle dulu kau cakap tadi.
Bukan, daripada right.
Oh right
ni,
menjala ke left
right, nampak septal tu, nampak gambar bulat ni, donat, nampak donat? Donat. Okey, main balik. Nampak? Daripada septum dia pergi ke left side.
Okey.
Nampak? So sepatutnya left side contract first, ataupun left side sekali dengan right side kan. So yang ni you can miss as cakap ada WMA.
Any other question? Kalau tak ada, okay. Just proceed. Okay. So in summary, Lbbb ni is difficult to see is there any occlusion lah. For example, macam tadi lah kan, dalam ECG tu kalau kita nampak macam tak nampak sangat the obvious, so it's hard to diagnose there is occlusion. And based on dia punya study pun nak cakap, okay, tak semua Lbbb akan ada occlusion. Okay, that's based on from the study lah. But kalau we have a patient, for example macam in my case, this patient come in with complaint of typical chest punya things. Okay, lepas tu kita buat ECG ada Lbbb. Okay, we calculate the Scabosa criteria dia, basically tak fulfill, but we still activate dia punya PCI. Why? Because based on the algorithm tadi, dia cakap kalau patient tu ada come in with Lbbb and also heart failure, the PCI will be benefit more to the patient lah. Okay. Otherwise, kalau let's say dia datang dengan more stable, kita akan kita still walaupun Scabosa dia tak fulfill, kita still have higher, orang kata apa, kita takut still ada occlusion lah dalam Lbbb ni. Kalau the finding, for example macam echo ataupun cardiac biomarker tu high, still PCI ni akan bagi benefit more to the patient lah. Okay, that's what I want to make a conclusion lah.
Adib, okay. Kalau patient ni kan dia datang dalam pukul 2 pagi, datang SOB, ada asma, so with that presentation, you call cardio kata thrombolyze. Would you thrombolyze this patient?
Okay, kalau untuk this patient, I will thrombolyze sebab the symptom is suggestive lah.
So you rather take the risk of patient having hemorrhagic stroke than to get safe PCI ke? But as you know this case, only 70% stenosis kan? Dia tak ada ATO, tak ada CTO.
So far tak ada.
So kalau you PCI, it won't change anything kan? The stenosis will be stenosis. Faham tak?
Faham.
So the guideline is just a guideline. So basically what this case is trying to tell you is, although there's a guideline, okay, you have to follow, but the safe way is your PCI. So if you get a thrombolysis in this patient will get a lot of complication but no benefit. Okay, the stenosis is still there. It won't open based just because you thrombolize. Okay, because there's a plaque kan, plaque that cause stenosis. So you cannot thrombolize the plaque. Okay, so this patient actually when I do echo, I was seeing this patient actually. The LV contraction is so good and it is hypertrophic, and the patient quite good respond to of NIV within 1 hour. So that's why I don't think this patient is having STEMI. Hello?
Oh, yes.
Betul.
So that's why when I do echo, I notice that the cardiac function is very good and the patient BP is so high. So I try to first drop the BP and clear up the lungs. So basically with my treatment, the ECG remains the same. Patient doesn't have any chest pain. So that's why I refer as STEMI with heart failure. Cardio saw and tried to thrombolize, but I disagree. Tomorrow they did PCI and noticed as 70% occlusion. Oh, that's why initially they said it's Minoka, but because there's no obstruction, to have an STEMI, you have to have coronary obstruction. Betul tak? So
Okay, sorry. Tak apa. Sorry.
that's why initially they labeled as Minoka. But as you already see, that Minoka you have only 50% or less kan. That's why in the end they on revised diagnosis as ischemic Lbbb with non-STEMI in failure. Faham tak? So kalau you ikut tengok balik dia punya pathway tu. You would kalau tengok suspected MI, Lbbb, new or old, you still will emergent preparation with PCI. That is the preferred strategy. But fibrinolysis only if patient having symptom of chest pain, very macam BP low. So you think echo pun ada abnormalities, ECG worsening, patient condition worsening, then you might sort of pergi fibrinolysis lah. That's why when you in research, you need to very careful lah. Just don't just follow the guideline saja. Because when you only follow guideline, you tahu that something is correctable lah, macam BP, macam hypertension, then you can correct, which will save the patient life but provide less complication lah. That's why this have to be case by case basis. So tak boleh lah kita hanya bergantung pada guideline dan thrombolize patient. So if cardio wants, I said to them, if you want you PCI now, I won't thrombolize this patient. Then cardio agree and the coros is done coming morning lah.
Lbbb alone dia akan affect cardiac contractility tak kan? Sebab dia punya current tu still sampai dekat myocytes belah kiri kan?
Dia akan progress lah basically. Maybe dia akan ada asymptomatic in early age, but it will give you symptoms later on lah. Kalau dia progressive.
Aku tanya sikit, what vessel supply Lbbb? Your left branch, which vessel yang supply?
Left circumflex.
Ya ke?
Dengan LAD lah.
LAD lah. So basically kalau ada LED obstruction, dia akan cause Lbbb. Descending. So basically kalau ada LED obstruction, of course lah lepas tu dia akan ada elevation dekat anterior lah, anterior STEMI lah kan, which you cannot see based on the patient punya ECG. Betul tak?
Betul.
So when you cannot see there's a Q wave there with ST elevation, then you tak boleh diagnose. So that's why yang the Lbbb sahaja tak boleh cause hypo contractility. The progression of the pathology that cause the Lbbb itself yang akan menyebabkan patient dapat low cardiac output lah because of the myocardial infarction. Faham tak Nakib? Nakib pula apa? Siapa ni? Daniel.
Nakib faham, aku pun faham.
Faham
Ya Syed, okay, apa etiology of Lbbb tu memang iskemia sahaja lah ya?
Tidak,
Sebab
tidak.
tadi adik kata
So,
apa, degeneration kan?
Ya, dia ada multiple cause. Ada satu study kata pasal semen lah, bukan semen. 192,000 semen dia punya apa kerja kapal lah. Dia buat study tu kata dalam 1% tak silap ada Lbbb below age of 30. So banyak cause of Lbbb, banyak ada yang genetik, ada degenerative, ada hypertension, ada LVH dan iskemia juga ada lah. So that's why we have to know, we have to differentiate whether this patient memang underlying Lbbb ataupun bukan, ataupun dia new onset Lbbb yang kita rasa is ischemia unprovoked otherwise. Menjawab soalan tak dia ni?
Any other
Okay.
question?
Jawab. Kau memang layak jadi pakar.
Okay, if there's no further question, okay, I'll back to the MC. Thank you. Assalamualaikum.
Thank you, Adik, for the very detailed presentation on
Okay, kalau tak ada soalan, kita proceed dengan next topik. Nakib, adik tak dengar. Mana ni? Nakib boleh keluar. Okay, Nakib. Okay. I think internet dekat sana tak bagus, so tak payah on video lah dekat bilik CME tu. Just slide is enough.
Okay, Bismillahirrahmanirrahim. Assalamualaikum. Thank you very much for choosing this lane. And I would like to apologize for this morning a bit delay on our part. So basically, I would like to proceed with my topic, which is chest pain post MI. So basically, when we have a patient that presented to ED with chest pain, So our first initial plan was to see for the life-threatening first. It can be not cardiac cause and it can be a cardiac cause. So basic for non-cardiac cause, it can be tension pneumothorax, it can be pulmonary embolism, it can be aortic dissection, and also for the minor one, it can be just acute dyspepsia. But otherwise, if patient have a history of recent MI, it can be due to reinfarction or having recurrent MI, or having ischemia or even pericarditis. So basically, after successful reperfusion, early recurrent angina occur up to 30% of patient at 30 days. Among patient undergoing primary PCI, 30% of patient report angina, which about 10-20% continue to have angina at 12 months. So these patients have a higher risk of recurrent MI and mortality, especially when the ECG and harmonic changes during the episode of chest pain. So this patient should be sent for early coronary angiography with a view of revascularization and can be treated optimally medically with antiplatelet, statin, anti-angina medication. So when we talk about reinfarction of recurrent MI, in-hospital reinfarction occurred about 3 to 4% of patients who had undergone fibrinolytic therapy and received aspirin. With primary PCI and DBT, the incidence of reinfarction and recurrent MI is not that frequent nowadays. So basically 1.8% at 30 days and 4% at 1 year. So a poor prognosis, especially if it's due to stent thrombosis. So basically reinfarction may be diagnosed by recurrence of ischemic type of chest pain or recurrence of ST elevation of at least 1 millimeter in at least 2 contiguously, and or the elevation of serum cardiac biomarkers, which is the CKMB or troponins, more than 35% in the increase the value from the last sample. So death, severe heart failure and arrhythmias are more common in this patient. They should be considered for rescue PCI. So basically, I will start with like my first case. So we have a 56 years old male presented to ED with complaint of chest pain, pleuritic light, having had history of STEMI last 2 weeks with successful thrombolysis. Otherwise, vital sign stable. So basically what we do next, basically we take the vital sign and everything is stable. So we do an ECG, basically because patient complain of chest pain, lungs totally clear. So this is what the ECG, what we find actually. So any takers to comment on this ECG? Anyone? Shafiq? Fidaus? Any takers?
Daniel Ikram aku rasa dia nak jawab.
Tak boleh, aku driving.
Anyone?
Daniel Chow.
Hi, morning.
Yes, good morning.
Soalan dia ECG changes kan?
Yeah, what does this ECG show actually?
So nampak SC elevation from the V2 to V6 and 1 AVL. Tapi tak nampak sangat reciprocal changes. Somewhat some PR segment depression over the lead 2. Tu je, tapi tak ada PR elevation at the AVR. So dia macam widespread SC elevation tapi given that this patient is 2 weeks post MI, right?
Yep.
Tapi tak ada Q wave lah, ni yang pelik. Tak ada TV emergent, tak ada Q wave. So tapi ada somehow got one macam concave punya SC elevation with macam ada J wave macam tu. So whether it's BR ke whatever, I can't comment now. I think it's better to repeat another ECG, see the serial, or I trace back the old ECG and compare.
So basically, I agree with Daniel. So basically, there's a PR elevation. There's a PR depression. We also widespread ST elevation to V2 until V6 without any obvious reciprocal changes. So basically, on the next slide. So if you can see, we talk about evolution of ST elevation ECG, just like Daniel Chow said. So basically, this patient doesn't have any Q wave after they have been thrombolized and having a STEMI last 2 weeks. So basically, as we see the evolution of ST elevation in ECG, the first changes that we will see is a hyperacute T wave. That's a sign that patient will go towards ST elevation, and then after hours, patient develop ST elevation start to begin as well. But after this, the Q wave deeper, and there will be T in wave inversion. And after days later, the ST elevation will be normalized with T wave inverted, and ST and T will be normal, and Q wave will persist weeks or later. But otherwise, if this patient having, as you can see here, during acute coronary occlusion, when there's a hyperacute T wave or minus, when there's a ST elevation within 0 to 12 hours, when we did a reperfusion therapy, so basically we just can see the terminal T wave inversion with later terminal T wave inversion, and later still there's no Q wave anymore. So basically, what we can say that it's possible that patient, if receive early reperfusion, patient will not develop Q wave. So basically, there's chances also that ST elevation will persist, but we're going to talk about that later because it will show a different diagnosis if the ST elevation persists. So basically, from the ECG, it really shows like acute pericarditis after MI. So basically, as we can see, there's a different how to differentiate between acute pericarditis, MI, and also early repolarization. So as you can see, ST segment will be concave in acute pericarditis as well as early repolarization, while convex in MI. Q wave will be absent in acute pericarditis, while MI will be present and absent in early repolarization. How about reciprocal ST segment changes? So basically, it will be absent in acute pericarditis, just like what we see in the ECG, and present in myocardial infarction, and also absent in early repolarization. So the location of ST segment elevation will be limb and pericardial leads, and myocardial infarction is very specific to the area of involved artery, whereas the early repolarization will be in the precordial leads. By that, we have the ST-T ratio height in lead B6, which is, I will show later, about more than 0.25. If my MI is non-available, less than 0.25 for early repolarization. PR elevation and ST depression AEVR, which is present in acute pericarditis and absent in others, and also PR segment depression in precordial leads except AVR, which is present on acute pericarditis and absent in other. So basically, this is how we differentiate between BER or also acute pericarditis. So basically, as you can see, the height of the ST segment is actually 1 millimeter, whereas the T wave height is actually 6. By right, if we divide 1 divide by 6, it will give a 0.16, which is the ratio is actually less than 0.25. It's consistent with BER. So whereas in pericarditis, as you can see the example, the ST segment height is actually 2 millimeter with T wave height 4 millimeter, and you divide 2 by 4, definitely you get 0.5, which is more than 0.25, and it's consistent with pericarditis. So the thing is, this patient having pericarditis after myocardial infarction, that's a specific what we call syndrome, which is we call Dressless Syndrome. Basically, acute pericarditis can be a lot of causes. And one of the causes can be viral infection, can be bacterial infection, can be because of the drugs, and it can be because of post-chest injury, and it can be because of post-MI or cardiac surgery. So what is Dressless Syndrome? It's actually a post-myocardial infarction syndrome. It's a form of secondary pericarditis. It can be with pericardial effusion or not. So basically, it develops weeks to months and rarely within the first week of post-MI. And the characteristic is the development of inflammation of the pericardium as well as another serosa. If it left untreated, it will be left scarring, thickening, and tightening of the heart. It will cause a constrictive pericarditis. So commonly, it will happen to 55 to 60 years old, 60 years of age, and symptoms include pericarditis, fever, chest pain, and pleural effusion. Okay. So basically, a little bit about Dressler is actually characterized by William Dressler at Maimonides Medical Center in 1956, which Dressless syndrome was historically a phenomenon complicating about 7% of myocardial infarction. So about 7 of 100 patients who actually have MI
end up with Dressless Syndrome. But in the era of PCI, it is very uncommon. So it's an immunoinflammatory disease similar to others that occur after myocardial injury, such as post-pericardiotomy syndrome and post-traumatic pericarditis. So basically, this is taken from European Society of Cardiology. As you can see, is a late post-myocardial infarction. It's called pericarditis after post-myocardial infarction pericarditis. So it should be considered on all patients who actually presented in ED with persistent malaise or fatigue follow MI, especially symptom present greater than 2 weeks following the event. So the symptom can be 3 to 4 days or 2 to 6 weeks post-injury. So with occasional symptoms developing a few months post-injury, the risk is higher if the infarction is actually larger during the MI. So basically, this is the sign and symptom that we see. But there's a triad typical to diagnose of pericarditis. Otherwise, this is the sign system: fever, malaise, pleurisy, chest pain, irritability, decreased appetite, palpitation, dyspnea, arthralgia, and pericardial friction rub. So basically, the diagnosis of acute pericarditis should be based on the presence of at least 2 of the following 4 criteria: the characteristic of chest pain that I will tell later, and pericardial friction rub, which is when during auscultation you can see you can hear like walking on the snow sound, and characteristic of electrocardiographia changes, the one that we already explained, and new or worsening pericardial effusion. So what is the type of pain that suggests to pericarditis rather than ischemic pain? So it can be central or left sharp, but more often dull. May radiate to shoulder and arm, just like MR, but worsen with deep breathing, coughing, or lying flat. Pain improve in sitting up and leaning forward, meaning it's positional dependent for this pain. So we really have to think about pericarditis. So a bit about pathophysiology is actually associated with immune system response to heart damage, which body reaction to the injured tissue by sending immune cells and proteins, which is antibody, to clean up and repair the affected area. So after MI, injuries to the cardiac myocyte expose myocardial antigen to the immune system, stimulating immune complex formation. The immune system activation triggers a systemic immune inflammatory response that may involve other organs, such as the pleura, due to immune cross-reaction. Sometimes this response causes excessive inflammation and on the pericardium. So basically, as we already explained just now, this is the ECG. So basically, the I forgot to say, that's a complication that patient will have the pleural effusion, or that can lead cardiac tamponade. So when patient with pericarditis, we can do echo to see whether how big is the pericardial effusion. But and patient also have a complication of constrictive pericarditis, meaning the harden of the pericardium that will make the contraction of heart impairment basically. So basically the management, basically we can give aspirin because it's a NSAID, basically a 600 mg 3 to 4 times per day. It can be acetaminophen or narcotic analgesic. It can be colchicine, even though in Dressler the data is not that a lot. And we can give glucocorticoid if there's a contraindication of aspirin and NSAID. And only after resolution of symptom and remission of CRP that the doses of aspirin, glucocorticoid, and NSAID to be tapered down slowly. Having said that, usually patient with pericarditis will have a raised CRP, raised ESR, and a raised WBC as well. So this is what the regime. This is what the regime that I can show you, and the type of medication, which is aspirin. We can do ibuprofen, indomethacin, colchicine, prednisolone, and anakinra. So this is the complication that I just talked about, which is the pleural effusion, cardiac tamponade, and constrictive pericarditis. So that was the first case, which is, in summary, is a pericarditis that happened after having myocardial infarction, which is the Dressless Syndrome. So we talk about second case, a 57-year-old male brought in by his wife who became concerned when he started complaining about chest pain. He had MI 4 weeks ago. So basically, this is the ECG that was taken on the self patient presented to chest pain after post 4 weeks of MI. Any takers to describe the ECG? Mana macam ni nak check? Anyone? Tiba-tiba kan tak ada orang kan. Cakap sekarang tak ada orang.
Ineligram ada ineligram. Tak tahu lah apa.
Seorang je target
Aku nak bawa sejauh mungkin daripada kau, Syed.
Desmond. Sekejap Desmond. Orang Penang. Sekejap
Wakil dekat Redbox. Redbox ramai orang.
Oh, Redbox. Wakil daripada Redbox. Nakib cakap Redbox ramai orang tengah tengok ni.
Faiza.
Kak Faiza
I try lah. I rasa left ventricular aneurysm post MI.
Wow. Tak payah describe the ECG. Nak describe the ECG first.
It's a sinus rhythm with a deep Q at V2 until V5, and there is ST elevation from V2 to V5. And this is juga. There's no ST depression or T inversion. And no reciprocal changes juga.
Okay, thank you. Is there anyone else who actually want to comment, or everyone actually agree with the description of the ECG by Kak Faiza just now?
Cik Kadir, ada apa-apa komen tak?
SK?
Driving.
Selayang
Dan driving.
Driving.
Semua orang driving pagi ni.
Ada accident kat Grand Saga ni, jam.
So tengah berhenti lah ni.
Besar kereta kau dia langsir.
Oh, okay lah. So basically dekat tu kita nampak lah VT V6 tu memang demonstrate a significant ST elevation, but there's no reciprocal changes. But do we take this as ST elevation STEMI or any diagnosis? Any comment?
Have to see all the old ECG. Sama ada time tu dah resolve ke tak the ST elevation.
Yes, boleh pula jawab. Okay, so basically I agree with Syed Kadir. So basically if we have the old ECG, it will be truly helpful. So we proceed, otherwise we proceed with the echo. So this is the echo lah basically, that kind of we did, no lah, I mean like the finding. Really? Oh. Okay. Any comment?
Continuous main. ECG ni? Echo ni? Continuous play. Boleh tak?
Continuous play?
Continuous play.
Continuous play. Okay.
Sebab dia orang nak komen tu pun dia kena tengok 3-4 kali. Anyone want to comment about the echo finding? This one particularly more obvious. Okay, sekali Andy. Okay, tengok slide seterusnya. Nampak tak?
Okay.
Hidayah Hanif. Tak jawab.
Ini ikram.
Hidayah.
Ya, play lagi sekali.
Oh, ini betul dah berhenti ni.
Kenapa RV collapse ni?
Alihkan fokus daripada RV ke LV. Apa yang kau nampak sekali? Sekali tengok LV je. Tengok LV tu, apa jadi? Cuba pause during systole. Pause during systole. Main video balik, pause during systole.
Alamak, sekejap. Apa pasal ni?
Okay, just click je tu. So this one during systole ke during diastole?
Systole tengah contraction.
Tunjukkan mana area systole.
This one as well.
Okay, the busted
microphone tutup.
Contracting kan? So, nampak tak dekat apex? Apa jadi kat apex tu? Dekat dia, apa yang jadi kat apex tu?
Macam ada paradox, dia macam opposite movement, paradoxical movement.
Yes, dia thin kan? Nampak thin kan? Compared dengan septal wall, dia nampak thin kan? So what do you think?
Dia dah lama dah kot.
Dah lama jadi apa? Pas dah lama jadi apa?
Aneurysm je.
Ada orang cakap tu, siapa tu? Apa jawapannya?
LV aneurysm.
Betul.
Jadi Kak Faizal dah jawab tadi. Kat sini.
Continue.
Okay, so basically patient having persistent ST elevation lah. So one of the criteria of LV aneurysm, patient having persistent ST elevation despite successful private reperfusion therapy. So this will be a challenge for us because especially in district ke apa ke, if we see a ST elevation, we tend to thrombolize this patient. But patient having LV aneurysm, patient will have no benefit if thrombolysis given basically. So following an acute STEMI, the ST segment return towards baseline over a period of 2 weeks, while the Q wave persists and the T wave usually become flattened or inverted. ST elevation remain in 60% of patient with anterior STEMI and 5% of patient with inferior STEMI. So basically we can see that 60%, 6 out of 10 patients that having anterior STEMI will have a persistent ST elevation. The mechanism is thought to be related to incomplete reperfusion and transmural scar formation following an acute MI. So the ECG pattern is associated with paradoxical movement on the ventricular wall on echocardiography. So this is ventricular aneurysm. So basically persistent ST elevation after STEMI, it can be LV aneurysm. So on the ECG, this ST elevation can be either concave or convex, will primarily be in precordial leads with relatively diminished T wave amplitude, which hyperacute T wave of whereas in STEMI. To differentiate LV aneurysm with STEMI is very challenging. So it will be helpful if we have the old ECG to see the kind of to compare the old ECG with the new presentation. Should that be unavailable, well-formed Q wave, absence of large or upright T wave, lack of reciprocal changes or dynamic ST changes leads towards LV aneurysm. So this will be make easier the factors favoring left ventricular aneurysm, ECG identical to perfect ECG, if available, absence of dynamic ST segment changes, absence of reciprocal ST depression, well-formed Q waves. factors that favoring acute STEMI will be new ST changes compared with previous ECG, dynamic and progressive ECG changes, the degree of acceleration is increased on serial ECG, the reciprocal ST depression, high clinical suspicion of STEMI will be ongoing ischemic chest pain, sick looking patient, pale sweaty with hemodynamic instability. So that's a formula we can count to actually differentiate whether patient having ST elevation or because of LV aneurysm or acute MI. So basically the rule number 1, we take the pericardial leads V1 to V4 punya T wave punya amplitude, and then we divide by QRS amplitude. If it's greater than 0.22, then MI is likely diagnosis. Yes. And at the rule 2, if we take one cardiac lead, T wave amplitude to QRS, if the greater ratio is more than 0.36, ST elevation MI is predicted. As you can see down there, T wave divided by QRS is more than 0.36 in any pericardial lead, STEMI. If T wave less than 0.36 is LV aneurysm. This is how we count it. As you can see, on the left, you can see the amplitude of the T is actually 5 boxes, and QRS is actually 11. So when T 5 divided by 11, the ratio will be 0.45, which is more than 0.36, which is towards MI. Whereas in the right side of the picture, as you can see, the T is actually 1.5 with QRS is actually 13. So if T divided by QRS ratio 1.5 divided by 13, it gives 0.11, which is less than 0.36. So this one, as you can see, kalau if you can see here, just as example, the T is actually required like 8 to 9 box, whereas the QRS is actually around 15. So 10-15 is 2/3 is more than 50%. So basically this is suggestive of MI, anterior MI. So this one is actually, if you can see, the T is actually around 5 to 4 with 20 for the QRS complex. So basically QRS amplitude, so basically is less than 0.36. So as you can see, this is the calculation from the ECG. I give a what you call kind of easier ECG to see lah, basically side by side. So as you can see here, this ECG, the one that we have been shown earlier. So we take like V1 0.15 divide by is still less than, tak nampak ni, nakit macam nak lihat 1.1 is 0.041, less than 0.36, and V2 0.4 divided by 2.0 is actually less than 0.36. V3 also less than 0.36 until V4. So that patient ECG really shows towards LV aneurysm. So confirming by the rule 1, with the sum of the V1 until V4, if you add 0.15, 0.4, 0.5 and plus 0.35 and divide by the sum of QRS amplitude 1.1 plus 2.0 plus 2.1 plus 1.8, we will get 1.4 divided by 7.0, which is 0.2, which is less than 0.22, though consistent with the LV aneurysm. So the thing is, the clinical importance, because ventricular aneurysm predispose patient to an increased risk of ventricular arrhythmias and sudden cardiac death because of the myocardial scar tissue is ethymogenic and congestive cardiac failure and mural thrombosis and subsequent embolization. So management by right LV aneurysm generally a poor prognosis, which associated with heart failure, CVA and ventricular arrhythmia, occurring around 38% of patients with MI. So 28 patients out of 100 can have a LV aneurysm. So patient having increased risk of ventricular tachycardia and ventricular VF as well. So basically, it will be helpful if we have echo for apical foreview, as we can see just now. We can see what you call widening of the apical side of the ventricle. So the treatment, this patient do not require PCI, but patient will be admitted for formal echocardiography, advanced imaging, and consideration of anticoagulation, as this patient are at high risk of arrhythmia and thromboembolic event. Okay, so the key point, acquiring an old ECG is key to differentiating LV aneurysm from anterior STEMI with a T wave amplitude. QRS amplitude assisting in differentiation. STEMI can be superimposed on LV aneurysm, and in this case, T wave again become upright with higher amplitude. LV aneurysm patients are at very high risk of dysarrhythmia and thromboembolic event. So basically, the key point what we trying to say is the patient having ST elevation after what you call MI with after fibrinolysis. We just have to know whether if can we try to find an old ECG and we try to compare. If not, we can use the criteria that been given to help in our diagnosis, and echo will be helpful before we start our treatment. So next case, a 70 years old man, known case of DM hypertension, uncomplicated angioplasty was performed using drug eluting stent to the proximal and mid RCA with satisfactory result after diagnosis of MI made last week. 3 days after the procedure, the patient returned to the hospital with severe central crushing chest pain. On examination, his heart sound were with no additional murmur. His chest was clear on auscultation. The jugular venous pressure was not raised, and there was no sign of decompensated heart failure. So this is the ECG was taken. Any takers, any to describe this ECG? I think straightforward one good.
Adri, kau jangan laju sangat, orang tak nampak history.
Oh, tak nampak history, okay. Dia dah pernah buat stand minggu lepas, and then dia datang balik dengan chest pain. Tapi dia tak ada failure symptom lah. So basically kita proceed lah, vital sign dia almost stable. So then we do ECG, and then this is the ECG finding. Wow. Describe the ECG.
Kepada sesiapa yang tak boleh nak turn on mic atau sebab-sebab yang tidak diketahui, contohnya Desmond, so boleh type dia punya jawapan dekat chat box. Radi nak jawab, Radi? Ataupun Zaim? Zaim nak type? Tadi Zaim dah dapat jawapan satu, correct.
Firdaus Yahya ada.
Deva ke? Deva? Nak jawab? What do you think of this ECG?
Sorry, was away. Anyway, nak describe ECG tu kan?
Dekat ECG je.
Ada ST elevation inferior leads to 3 ABF. Lepas tu ada ST depression, ada reciprocal changes ke? Kejap. Ada ST up kat mana lagi? Kat V4, V5, V6 pun ada ST up juga. Got ST depression V1 to V3. So this one got inferior MI lah. Lepas tu ada posterior involvement juga sebab ada ST depression V1 to V2. Lepas tu right sided involvement tu ada juga sebab ST elevation kat lead 3 lebih daripada. Tu je.
Okay, understandable. I agree with the statement. So basically, what she said, there's ST elevation to 3 AVF, which is inferior lead, and there's also ST depression of V1, V2, which is highly suspicious of a posterior involvement as well. And right-sided involvement, because there's a what you call 3 higher than 2. So basically, there's a shows of involvement of the right-sided as well. So because this patient having what you call MI and having PCI done, so alamat tak boleh gerak lagi. So basically patient having reinfarction lah basically, and most likely is actually a stent thrombosis. So because patient having PCI, as already stated, 3 to 4% patient who had undergone fibrinolytic therapy and received therapy have in hospital reinfarction. 3 out of 100. Even with primary PCI DAPT, the incidence of reinfarction and recurrent MI is not frequent. Meaning that after introduction of PCI, if actually 1.8% at 30 days and 4% at 1 year. So the poor prognosis will be if patient having stent thrombosis lah. So basically the time frame of stent thrombosis can be acute, subacute, late stent thrombosis, or very late stent thrombosis, which is differentiated by the days itself lah. If less than 1 day is acute stent thrombosis, likely will be handled in ED lah, because patient will be still in cardio ward. So subacute 1 day to 1 month and 1 month to 1 year is late stent thrombosis, and more than 1 year is very late stent thrombosis. So basically there's a 2 type of stent that being used. So basically is what you call a bare metal stent that having been used for a long time, and then there will be introduction of DES, drug eluting stent, which is actually a bare metal stent that having drug that to what you call to avoid from the vessel becomes stenosis. So early within 30 days or late, in general, early stent thrombosis usually happen around 50 to 70% of all cases of stent thrombosis. So as I said just now, so there's a bare metal stent and also drug eluting stent. Can cause 2 types, which is stent thrombosis or in-stent restenosis. In-stent or restenosis to meaning the vessel itself narrowing. By right, the stent thrombosis meaning there's a thrombus development in the area of stent. So basically, the bare metal stent have higher incidence rate, which is 30.1%, whereas the DES is less than 5%. So because the added advantage of the receiving of anti-proliferative drugs that reduce neointimal proliferation, thus resulting in lower rate of ISR. So basically risk factor of stent thrombosis, it can be clinical, angiographic or procedural, which is the clinical benign compliance to medical therapy, diabetic, renal failure, young age, smoking, presence of malignancy, and stenting for myocardial infarction. With angiographic, small vessel diameter, the use of long stents and multi-vessel disease, which is more than 1 vessel, 2 or 3, undersizing of a stent, bifurcation stenting, and also dissection. This happen during the procedure. So if the patient doesn't take premature cessation of antiplatelet therapy within first 30
ada internet problem ke? Adri, mute. Kau mute. Muted. Ada masalah internet. Boleh ulang balik 5 minit sebelum ni.
Alamak. Share.
Nampak stop tadi.
Mana? Dah share screen.
Tak ada lagi screen.
Ni.
Sebelum tu aku nak tanya, kalau patient tu STEMI, lepas tu ada stent, dia punya type of MI type apa?
Kau type 3 ke? Type 3 MI kan?
Ya ke type 3? Ya ke?
Ke type 4? Type 1 because of the thrombosis event. Type 2 is because of oxygen demand punya problem like anemia, so on. Rasanya type 3. of CBG type 2.
Type 4.
Type 4, sorry, type 4.
Type 3 dulu autopsi kan?
Type 4.
Type 3 sudden death.
Tu autopsi nampak, tu type 3. Type 4 is stent. Type 5 CBG. Belakang lagi?
Belakang lagi.
Previous slide. Okay. So tengok depan lagi.
Depan.
Okay, so macam ni apa yang cakap? 1.5 with BMS, 2.2 with first generation DES, 1.0. So first generation DES adalah lebih buruk, lebih tidak bagus berbanding dengan better stent, betul?
Betul.
So conclusionnya gunalah second generation yang above lah.
Yang the latest one lah, up to date.
Latest one lah. Okay.
So this is the risk factor. Basically, clinically, in clinical, non-compliance to medical therapy, patient having underlying diabetes, renal failure, young age, smoking, presence of malignancy, and stenting for myocardial infarction, primary angioplasty. Angiographic-wise, small vessel diameter, the use of long stent and multivessel disease, and procedural is the undersizing of stent, bifurcation stenting, and dissection. So we can predict patient having stent thrombosis if I had premature cessation of the antiplatelet therapy lah within the first 30 days. So it's very important to emphasize of patient to take on antiplatelet therapy. So the management, the immediate management of stent thrombosis is the same as the management of acute coronary syndrome. So successful reperfusion of acute myocardial infarction from stent thrombosis is less likely for acute myocardial infarction due to native artery plaque and rupture. But from my experience last time, during my time at district hospital, when patient having history of like 1 week of PCI and patient having ST elevation with chest pain, there's my EP last time dia cakap tak perlu nak thrombolyze lah. Dia kata better kita call untuk PCI lah, which is will take 1 hour. So by right, dia kata kat sini if kita bagi thrombolysis tu, the successful reperfusion tu will be less likely lah. So last case.
Yelah, maksud dia kalau you thrombolyze pun tak guna sebab dia punya success rate rendah. Sebab apa? Sebab dia adalah inflammatory process. Faham tak? When you stent, there's inflammation. And that inflammation process won't go away with your thrombolysis. So you need to re-stent balik.
Is it wrong?
Is
it wrong to thrombolyze? Initially we take that what you call.
Then kalau you tahu dia less likely to be successful, macam okay, maybe dia punya success rate is 1%.
Okay.
Then would you subject this patient to complication?
No, that's the thing. That's the complication.
Kan? Yes. Bukannya thrombolysis tu bukannya is safe kan? So
especially dekat distal lah pakai streptokinase dia.
So we have to consider lah when we get this patient, kita kena bagi tahu lah, oh you dah buat PCI, maybe this is your PCI block. So we need to re-PCI ataupun hantar you ke ni lah. So in the meantime you start lah all the DAPT, antikoagulan apa semua.
So refer for PCI lah.
Have to.
So the last case, 70 years old female presented to ED with acute shortness of breath and bilateral leg swelling, and patient having new onsets of optopnea over preceding weeks, history of MI with PCI done 1 week ago. On general examination, she was hypotensive, blood pressure was 77/62, her heart rate was 90, and she was tachypneic lah, with oxygen saturation 98% under oxygen, with bipassal collapse and a new grade 5 pansystolic murmur. So this is the ECG. Any takers to describe the ECG that have been showed now? Anyone?
Tadi new request refund tadi.
The Irfan. Anyone?
Ini normal sinus rhythm ni.
Yelah, normal sinus rhythm lah. So there's no ST elevation. As you can see, there's a regular with P and also not tachycardic lah basically. So, and then we proceed with the echo. Lama dia dah tunjuk. Anyone want to comment regarding the echo? DI ada DI?
Zaim jawab BSR, betul?
Betul. Boleh nampak lah actually.
Zaim jawab VSR. VSR tu apa?
Ada connection unstable pula. Aku tersekat. Boleh.
Zaim jawab VSR.
Short form tak tahu lah short form. So as you can see in the echo, so you can see the septal actually there's a decontinuation lah dekat bahagian middle part. Actually is going to zooming. So as you can see in the color Doppler as well, color Doppler as well, there's a leaking. I mean that's a ruptured over the septal region of the left ventricle. So 82% of post-infarction ventricular septal rupture demonstrate left ventricular enlargement. With 78% we have a pulmonary edema and 64% we have a pleural effusion. Although these findings are non-specific, do not exclude other causes such as ruptured papillary muscle, which can be cause of complication of post-MI as well. So a bit of epidemiology, a bit of history. 1847, Ledham first mentioned the diagnosis of VSR occur within the first week after AMI. Size of the rupture determine the prognosis of the patient. The prognosis is good if the rupture is small and the patient is hemodynamically stable. So before the ability of thrombolytic and PCI, there's a 2% incidence of the VSR. But after the introduction of PCI, it was 0.31%, which is and also fibrinolytic. So with PCI account for 0.7% incident after MI and thrombolytic therapy 1.1% happen. So the type of myocardial infarction incident also precipitated to VSR. STEMI 0.9%, non-STEMI also have 0.17% chances to have VSR, and unstable angina for 0.25%. So there's no difference in the rate of ventricular septal rupture based on the location of infarction, whether it's entry infarct or infralateral infarct. So basically, the most common ventricular septal rupture is a full thickness transmural myocardial infarction in one of the following coronary arteries. So basically, LAD, because LAD supply most of the anterior portion of intravascular septal, it can lead to apical VSR, and dominant right coronary artery supplies the most inferior portion of intravascular septum. This can lead to basal VSR. The dominant left circumflex artery supply the posterior portion of posterior descending artery and rush from the circumflex branch. Patient that have likely to have a VCR usually will have a infarction in LAD and also right coronary artery, because this phenomena, what we call wrap around phenomena, because these two blood supplies supply the intravascular septum. So having infarction in both of these artery, the LAD and also the RCA, patient will likely to have a ventricular septal rupture. So we have to be aware of that. But fortunately, if patient came, I mean like usually there's a lot of patients actually have a sudden death due to worsening of ventricular septal defect, rupture. So this is the type of ventricular septal rupture. We have simple and complex as well. So the clinical features will be hypotension, chest pain, shortness of breath, harsh hollow systolic murmur, trill, S3 sound, loud S2 sound, pulmonary edema, left or right ventricle failure with cardiogenic shock. So based on ECG, there's no features to diagnosis of post-MI VSR basically, ventricular septal rupture. So the echo finding, we can see a regional wall mesh abnormality because of the septal rupture, VSW defect, ventricular septal wall defect, and left to right shunt on color Doppler. As you can see just now on the echo where you can see color, there's a left to right punya movement. So the risk factor will be female gender, increased age, first episode of MI, ST segment elevation, myocardial infarction, high risk score, and chronic kidney disease. So the treatment is basically surgery. That's the main treatment. So basically, if patient having, we have to stabilize the patient. Obviously, if patient having, kita nak turunkan dia punya afterload, we use vasodilator, and we can give inotropic support. If patient having low cardio output, and if can, we can give intra-aortic balloon pump lah, basically. So surgery should not be delayed in following cases. If there's no evidence of cardiac shock, patient having good perfusion and cardiac output, minimal or no sign of congestive heart failure, minimal use of vasopressor, no retention of fluid, or normal kidney function. So there are two surgical techniques. So basically, if this patient came with CBSR, we just have to refer cardiothoracia just to know they have Daggett procedure and also David procedure, which Daggett procedure with patch over the defect, which stitched in both the ventricle, and David procedure patch over the rupture, which stitched in the left ventricle only. So as I can say, the other treatment is percutaneous closure as well, which we can use a balloon catheter. So untreated VSR has a mortality of 40 to 80%, and late surgical intervention has a good prognosis only in hemodynamically stable, meaning we have to delay the surgical if patient then vital signs still stable lah, basically. So surgical intervention within 7 days carry higher mortality, which is 54.1%, and more than 7 days will be 18 and 4% incidence. So that's all the cases that we have discussed today. Any question?
If there's no more question, ada
ya,
yang
aku cakap boleh sebab ni aku nak tanya apa how sewajib manakah reciprocal changes tu kena ada kalau patient ada STEMI? Adakah how dia punya frekuensi ke atau inilah macam baru kita boleh kata ke, kalau reciprocal baru boleh kata wajib, dia punya kewajipan tu sejauh mana?
Dia wajib macam mana cakap ni?
Actually memang ada yang tak ada reciprocal changes pun, but we can still
wajib ke sunat ke?
Dia tak wajib kan, dia ada percentage patient that don't have reciprocal changes. Berapa persen aku nak cari, lupa lah kan bos, betul kan Dr. Syed?
Reciprocal changes kalau ada maksudnya supportlah diagnosis. Contohnya macam anterior MI, mana ada reciprocal? Anterior MI tak ada reciprocal. Posterior MI kau tengok yang ST depression tu, itulah reciprocal. Betul tak? Kalau lateral MI, reciprocal dia kat mana? Kalau lateral MI pun tak ada reciprocal.
Tak ada. Inferior ke anterior?
Dekat inferior. Inferior kot. Kalau inferior MI reciprocal kat mana? Lateral lah. So basically ECG, our lead placement will show that kalau ada significant ST elevation, there will be a reciprocal changes dekat contralateral leads. So how important it is? It is very important, and it will help you in diagnosing MI lah. So kalau you nampak reciprocal changes the ST elevation, then your diagnosis will be MI antiprobat otherwise lah kan. Kalau you tak nampak you nampak ST elevation tapi tak ada reciprocal changes, you might not think that it is an MI. You boleh fikir ada differential lah basically. Contohnya macam LVH, macam Lbbb, macam pacemaker, mana ada reciprocal. So I think reciprocal changes, it is helpful in certain leads, but as you know that if you don't see also, you have to repeat ECG, tengok whether it's true or not, ataupun rule out ada differential diagnosis.
Ya, aku ada lagi satu soalan. Apa tadi Hadri? Kau cakap tadi okey, nombor satu, kalau STEMI kita kita perfuse early, dia takkan develop, dia takkan progress kepada permanent ST elevation kan? Kau cakap tadi. Ke? Okey. Lepas
LV aneurysm lah. Kalau dia persistent ST elevation, dia kena ventricular aneurysm lah.
Yalah, so kalau perfuse early, dia sepatutnya kita boleh prevent benda tu lah kan? Okey, lepas tu apa kan ada kau tunjuk gambar tadi yang apa entah kalau perfuse awal, lepas tu dia tak akan progress ke apa. Lepas tu tapi kau cakap juga yang STEMI can be superimposed on aneurysm. Kan? Ada cakap tadi kan? Okey, kalau kawasan tu dah kena STEMI, lepas tu dia kira apa ke nama dia, dia jadi aneurysm, that means that part dia dah kira dia boleh affected semula ke in the future, that region of the heart. Kalau cakap, sebab aku ingat macam ni, aku ingat kalau let's say that region of the heart dah affected kan, dia dah kena infarct, so lepas tu dia jadi jadi aneurysm pun semua, dia kira macam kawasan mati. So macam mana masa depan pula dia boleh STEMI lagi kat situ on top of the aneurysm kalau kawasan tu dah affected dah.
So sebab tu kita ada kriteria tu nak compare dengan last ECG tu, because bila kita tengok ST elevation dia not as high as kriteria untuk ST elevation tu. So basically this LV aneurysm lah, but on top of that kalau dia masih ada MI dekat kawasan sama, of course dia akan develop new ST elevation, because patient mesti totally not infarct, not totally transmural infarction, because tak ada Q wave pun yang develop kat situ kan. Kalau
dia sebenarnya dia Hadri jawab dia, Daniel ni kena jawab balik dengan soalan.
Soalan balik.
Okey. Daniel.
Ya.
Daniel dengar tak?
Ya, aku okey. Ya, dengar.
Adakah mati akan kekal mati?
Soalan.
Dalam Quran macam tu lah.
Tak. Kawasan yang mati tu, adakah dia akan kekal mati? Ataupun ada benda lain yang jadi?
Okey, setakat aku ingat 3 types apa nama dia, cardiac dengan brain tissue ni tak boleh regenerate kan. Okay. So apa nama dia, it reflects on the mortality of humans juga lah kat situ. Apa nama dia, tapi itulah maybe macam Adi cakap tadi, kalau bukan transmural, okeylah aku boleh, that means possible lah untuk masa depan tu dia, maksudnya patient ada develop that permanent ST elevation di depan, mungkin dia arteri tu kena kira macam dia kena, lepas tu kita thrombolyze tapi lambat, so we did not manage to prevent the permanent ST. Lepas tu tapi balik kat situ. Boleh tak macam tu? Sebab aku
Nombor dua soalan.
adakah dia punya pathophysiology?
There's a principle of Daniel, there's a principle of healing lah. Healing process, mana ada fibrosis, angiogenesis, blood vessel, new blood vessel formation apa semualah. So okay, walaupun dia healing, but the heal this it cause fibrosis lah. Or memang myocyte dengan angiogenesis dia akan keluarkan apa fibrocartilage, collagen apa semua, dan dia akan repair that tissue causing fibrosis. That's why patient on top of that dia ada aneurysm. So when that similar vessel apa got obstructed changes. Faham tak?
Okay, so dia punya ni lah, dia punya jiran kawasan dia tu. Maksudnya bila STEMI on top itu impose on the aneurysm tu.
Yes.
Beres.
Okay. Thank you very much for cooperation.
Mute.
Okay, thank you very much for having us today. So we would like to proceed to our third presenter, Dr. Nakib, with all due respect.
Nak toilet break dulu ke ataupun nak continue?
5 minit lah toilet break.
5 minit toilet break, makan ke apa ke, minum air ke. Nanti kita continue lagi 5 minit
Okay. Dia dapat emission kat lain pula kot. Yang aku tak tahu yang ni itu aku tak tahu pasal fisiologi macam ni.
Ya. Betul lah. Once dia dah impak, dia akan mengikut irrigation.
Okay, Nakid dah start.
Okay, we start. Assalamualaikum warahmatullahi wabarakatuh and good morning to all my colleagues, to our respected EP Dr. Syed Muhammad. Okay, before I start our third case today, I would like to announce there are some announcement. Today there will be a Kahoot prepared by Dr. Safia Hani, and one of our presenter are willing to donate his money as a token of appreciation for the first, second, and third participant who get the highest answer. So the appreciation will be in a e-wallet form. So the amount will be no later lah. Kita rahsiakan dulu, okay? So we start our third scenario. There is a 52 years old lady presented to emergency department with the bilateral lower limb burn injury 2 hours prior to the arrivals. So the TBSA calculated is 22%. The Parkler regime was started by our colleague. And upon receiving the treatment in ED, patient complained of chest discomfort and dyspnea. The vital sign taken, the BP is 100/60, pulse rate is 110, SpO2 95% under room air. And what are the differential diagnosis? What are you thinking when you get this patient come to our ED with the severe burn injury while waiting for the completed the treatment? As long maybe there are some issue with the backlog, patient receive treatment in our ER. So patient complain of chest pain and difficult to breathing. Maybe you are a TL on the floor. Your colleague activate you to get some inputs. So anyone to share what is your cross in your mind when you deal with this kind of the cases? Pernah
Tapi
tanya?
Dr. Nakib, dekat dalam tajuk ni pun dah cakap dah takut subuh.
Tapi tak confirm lagi time ni. Sebab masa ni takkan you mungkin kalau EP datang ni takut subuh ni. So apa yang you cross on your mind? If you are not EP yet lah. Maybe are you thinking of something that you miss, or something maybe common, or something rare like okay, takut subuh is last choice lah, other than takut subuh.
So it's good to have a differential lah. So basically this patient came to you in shock, kan? Patient came to you in shock after burn injury. Okay, good. Desmond jawab PE. Any other cause, Desmond? Patient baru 2 jam, takkanlah sepsis. Apa lagi?
Inhalation injury.
Betul.
Siapa tu? Khalil. Tapi tak ada hadiah lah. Okay. Lagi ada?
Zaim kata carbon monoxide poisoning, betul ke?
Okay. Dia chest pain, dyspnea. Okay, maybe one differential.
Carbon monoxide, Zaim. Selain daripada carbon monoxide apa? Kelang terbakar. Dia inhalation juga. Cyanide, betul. Cyanide poisoning lagi akan cause shock lah compared to your carbon monoxide. Sebab cyanide cause cellular shock kan?
Shock.
So cyanide is more important than carbon monoxide. Carbon monoxide dia cause hypoxia saja.
Okay, ada
rhabdomyolysis. Betul. Lagi? Apa lagi differential? Patient burn 22%. Mana fluid dia pergi? Betul, extracellular.
Hypovolemic from Zaim, hypovolemic. Third space loss, okay, from Desmond. Okay, I think a lot of differentials. Just want to share. Okay, maybe
another thing, you have to make sure that you know what caused this burn. Okay, entry point, exit point, dia ada kat mana? Dekat elektrik ataupun dekat lightning lah. So basically kalau you nampak this thing Burn injury, you might consider electric. So you kena tengok exit point. Kalau ada. So it can cause ventricular arrhythmia, boleh cause shock jugalah.
Thank you, Dr. Syed. Okay, this is just my list, what is causing my mind. Maybe there's a upper airway obstruction, secondary inhalational injury. Although the other one, maybe we miss something that we focus. Maybe our paramedic say patient just come because of the lower limb, tapi kita tak fulfill expose, patient ada also burn dekat chest wall. We can make a difficult for the expiratory and expiratory process due to the superficial full thickness of the burn chest wall. Other thing is bronchospasm due to smoke inhalation. Maybe patient is underlying bronchial asthma. Possible patient have this pneumothorax, traumatic event when having the burn injury. Also patient could be develop the ARDS, even though the ARDS usually is in burn is not developed so fast within the 8 hours of period of fluid infusion. And is this patient have the true MI? At the same time, patient come to our ED with the burn injury. So it's some of the idea that should cross in your mind when you are encounter this like of cases. Okay, so we proceed with ECG because patient complain of the chest pain. Anyone to comment of the ECG? Maybe after 2 lecture from the Hadri and also the Adib, so all of you can master easily to see, or this is normal ECG, or maybe some changes that lead our diagnosis. Boleh tulis kat komen. Suhaila ada lagi? Ke tidur lagi? Dan Ikram boleh rehat kejap kot. Nak cuba pun boleh. Is there any evidence of myocardial infarction or evidence of PE as mentioned by Desmond? Okay, from Desmond, this is a normal rhythm, P wave is present, J point elevation over the chest lid. So the obvious at the V2, V3 and V4 lah. That's from Desmond. And then anyone? And also at the inferior lid, 2, 3 and AVF. So Desmond is fulfill the MI criteria. Should we activate cardio? Is in this case? Okay, it doesn't fulfill the criteria. Okay, then because we get the new echo from Uncle Kentang, so we get the new echo and we do the echo to see if any abnormality. Okay, I replay back. Any comment regarding the echo? Okay, from Desmond, heart contractility is look good, but RV is under volume. Kita tak bernasib baik hari ni, tak dapat dengar suara Desmond secara live. Tapi tak apa. Anyone want to comment back? The echo?
Boleh replay balik tak? During the systole, tunjukkan dekat Desmond. Pause during systole.
Okay.
What do you see, Desmond?
So any?
Can you see the apex?
Yeah.
Yes. So if patient ada previous MI, what is your diagnosis? Baru tadi kita discuss. If patient had 2 weeks MI, before that, what is the diagnosis?
As presented by Hadri.
LV aneurysm. So you can see there's apical wall thickening and hypokinesia. So kalau macam ni, without any history of MI, what is your diagnosis?
So Takotsubo. So we can see from the echo when the systolic phase, there is the apical ballooning, and also there is hypercontraction dekat dia punya apical, the base area. So like I will present later, make a shape like a Takotsubo, which is the octopus trap based on the history. Okay, now our focus today, we want to discuss is the Takotsubo Cardiomyopathy, which is in this case is precipitating by the acute event of severe brain injury. So actually, what is Takotsubo Cardiomyopathy is the transient apical and mid-ventricular LV dysfunction in the absence of the significant coronary artery disease that is triggered by the emotional and physical stress. So in these cases, is caused by the physical stress, which is the severe burn injury. So in the setting of depressed and abnormal function of the register and apical LV, there is compensatory hyperkinesis at the basal wall. So that's lead to the presenting of the ballooning of the apex during the systole phase, which is this is transient phase, which is can be recovered normally LV function after 1 to 4 weeks. So this is the history described in Japan, 1991. So named after the Tako and Subo, which is octopus trap, which is the similar appearance of the LV ballooning noted in the patient with this the form of the cardiomyopathy. So we can see the shape of the heart with the shape of the trap is resembled. So by the echo, we can see at the end of the systole, there will be ballooning of the area of the apical compared to the area of the basals. So the other name of the Takotsubo is stress-induced cardiomyopathy, transient left ventricular apical ballooning syndrome, broken heart syndrome, which is common we use, and ampulla cardiomyopathy. So the epidemiology is about 1.7 to 2.2 patients who have suspected acute coronary syndrome, subsequently diagnosed with Takotsubo cardiomyopathy, which is most in ASEAN, about 47.2, and the mean age is about 67 years. And also 90% is post-menopausal woman. So any woman come with the age is more than 60, post-menopausal, and mostly ASEAN with the physical or emotional stress. So we have to look, is any possibility of we dealing with the Takotsubo cardiomyopathy or broken heart syndrome. So the criteria post for diagnosis the cardiomyopathy of the Takotsubo need to include all 4 criteria, which is transient hypokinesis, dyskinesis, and akinesis of the LV mid segment. Without apical involvement, there will regional wall motion abnormality beyond the single epicardial vascular distribution, which is usually have the successful triggered, but not always present. The second one is absent of obstructive coronary disease or angiograph evidence of acute plaque fracture. And the third one is new ECG abnormality or modest elevation of cardiac troponin, and also absent in the pneumochromocytoma and myocarditis. So the pathogenesis is because there are some mandatory, then the most common theory is about the catecholamine excess, which is elevated of the norepinephrine is more than 75% in studies, which is more higher than patient develop MI. So they will induce the microvascular spasm and dysfunction, lead to the myocardial stunning or direct myocardial injury. So that lead to artery spasm and lead to the hypokinesis at the apical region, and also hyperkinetic at the basal region as the compensatory mechanism. So this is the flow when they have the emotional and physical stress. So excitation of the limbic symptom increase the norepinephrine and lead to the beta receptor at the level of the heart, most likely at the level of the base compared to the level of the apical. So lead to the ballooning of the left ventricle. For the receptor part, alpha receptor will lead cause to the contraction of the artery with impact of the flow of the microcirculation of the coronary artery. So there's a study to show that comparison between the catecholamine level in Takotsubo and also the MI, which is higher in Takotsubo in all phase day 1 to the day 8 of presentation of the Takotsubo and MI. So the classic presentation mostly is female. The age is 68. 80% of patients will have the increased cardiac troponin. With the ECG, there was 44% we have the ST elevation, and 8% have the ST depression, and also 48% have the prolonged QTC. And half of the patient have history of the psychiatry or neuro condition. So for the emotional or physical triggers factors, we can see the most common is physical triggers, and the second one is emotional triggers. For the emotional triggers, the most common one is grief loss. So any patient have the loss of their beloved one come to ED, so we have to suspect patient have the Takotsubo Cardiomyopathy, especially during this pandemic event, ramai yang meninggal kat rumah kan. So the family members maybe have some emotional trigger that lead them to get the Takotsubo. For the physical triggers, for the acute respiratory failure is the highest one, and the second one is post-surgical and also fracture. So the presentation is kind of similar to the MI. Patient can come to with the substernal chest pain, ECG abnormality, which is ST elevation, ST depression, T elevation, and QT prolongation and abnormal Q wave with elevated cardiac biomarker. So patient come also with the dyspnea, shock, and syncope. So what is the difference between the ECG in Takotsubo and also the MI? So the ST elevation is about 67 to 75%, and T elevation is 61%. Most likely at the precardiolite, which is a V2 to V3. So comparison of MI with our Takotsubo is the Takotsubo have the ST elevation, which is a lower amplitude of ST segment elevation, like mentioned by the Desmond. So the patient doesn't fulfill the MI, but still ada evidence of ST elevation. Part of that, it could be normal also in 50% ECG normal. Diffuse T elevation can occur in the day to the weeks, and also they are study for the 33% patient we have Takotsubo. So the suggestive about 91 sensitivity and 96 specificity for Takotsubo when the absence of abnormal Q wave, absence of reciprocal change, lack of ST elevation in lead 1, and also presence of ST elevation in lead AVR. So the echocardiography patient will be presented with the apical ballooning, mid-ventricular, inverted form, either LV wall motion abnormality, coronary flow in distal LED, and RV involvement. I will show later. There are 4 types of echo in Takotsubo. The complication is LVOTO, moderate to severe mitral regurgitation, intraventricular thrombus, and cardiac rupture. So when patient come with chest pain, that we thinking of patient having similar to SCS. So anyhow, we have to proceed with PCI if available, if the ECG is suggestive of MI. So otherwise, to prove that patient having the Takotsubo based on the ventriculogram and also echocardiography, which the EF is reached about 20 to 49%, and there's have the atypical can also have the atypical ballooning of the middle and basal portion. Part of that, they have the LV outflow tract obstruction about 16%. and also the cardiac catheterization reveal lack of flow limiting coronary lesion or evidence of plaque rupture. Okay, this is the fourth type of the Takotsubo cardiomyopathy. The type 1 is the apical type. We can see from this graph. So there will be the weakness at the apical compared to the other vessel and mid ventricular. So the second type is about the mid ventricular. We can see the blue dot. So there is a will be the dyskinesia at this part. So the third type is basal type at the basal area, and the type 4 is the focal area. So the acute complication, patient will come with tachyarrhythmia or arrhythmia. Patient will have the pulmonary edema or cardiogenic shock, transient LV outflow tract obstruction, mitral valve dysfunction, and also acute thrombus formation and stroke, and patient will come with that. So the management part, as I said before, we have to treat as SCS until proven otherwise. So we secure the airway with this circulation, put cardiac monitoring, do the ECG, take all the bloods, especially the troponin, also cardiac biomarker, and also we have to optimize the pain management, and then we have to serve the standard therapy for SCS. Maybe indicated, and also if patient have congestive heart failure, may require dialysis, and also if patient have shock, need to give the fluid and also inotrope based on patient condition, as if patient have the LVOTO or not. Okay, for patient who have the cardiogenic shock, we have left ventricular outflow tract obstruction. So the main primary is we have to cautious fluid resuscitation, and also we have to trial of inotropic support such as dopamine and dobutamine for temporary measure, because they have can cause the mild LVOTO in these patients. For the moderate to severe, the inotrope is contraindication because it can make a worsen of the obstruction, and they should be close monitoring with the intra-aortic balloon pump (IABP), and this later on can support with the vasopressor. For those who have the they have studied by the Ansari that inotrope such as epinephrine, norepinephrine, dobutamine, and dopamine should be avoided in Takotsubo because the catecholamine can access more than increase up to 30 days and long-term mortality. So the recommendation is fluid resuscitation in the absence of pulmonary congestion for those who have the severe LVOT, and also the use of beta blocker to relieve the obstruction because it can block the catecholamine. And part of that, their studies show that using the esmolol may help, and also followed by the initiation of the beta blocker like the bisoprolol can improve the obstruction. As I mentioned before, for the severe one, we can also try give the phenylepinephrine to increase the afterload, and also patient may require the close monitoring and also the intra-aortic balloon pump, and also if still worse, can proceed with the extracorporeal membrane oxygenation. Also, if patient develop arrhythmia, studies show the most common is bradyarrhythmia, so that need a permanent pacemaker implantation. For those who have the VT, can put the temporary cardioverter defibrillator, and for the patient who have arrested, so we proceed with the SLS per protocol. So we going back to our discussion. So in this patient with the burn injury with Takotsubo, so the problem is we know patient have the third space loss and also rapid displacement of the intravascular fluid because of the activation of all the complex immune system. So patient will consider as the burn shock, which is combination of the distributive hypovolemic and cardiogenic shock. At the same time, when patient get the Takotsubo, so we have the problem with intravascular and also the pump failure. So the aim is to maintain the tissue perfusion, so we can give the adequate resuscitation, but at the same time we have to watch out for any evidence of worsening of the heart failure caused by the Takotsubo. So the mainstay of the treatment, we have to give the adequate pain management,
and look for any risk of fluid congestion after giving the fluid, and also need close monitoring. And we have to reassess by the echo, look for the presence of LVOT, if present, and then we decide aided anatomical support indicated or not based on the severity of the LVOT. So as conclusion, Takotsubo is good prognosis, and long-term prognosis is excellent because it's transient, and the hospital mortality is low, closer to 1 to 2, and recovery is about 1 to 4 weeks, and the late sudden death and recurrent disease have less than 10% only. So as take home, the Takotsubo is transient based on the finding of the echo, triggering by the significant emotional and physical stress, and could be like similar as MI. So we can proceed with the PCI if available, and if patient need for the giving the fluid, so we have to give a caution list to avoid balancing having the complication or worsening of the heart failure. Okay, that's my preference. So any question can ask, and Dr. Syed Muhammad will be answered this question.
Presenter jawab.
Okay.
Nakib.
Ya.
Apa nama dia? Kau cakap tadi boleh pakai phenylephrine kalau as treatment to increase afterload.
Okay, phenylephrine ni dia more towards dekat dia adalah more to alpha blocker. So dia dekat our vessels, make the vessel constriction. So for the temporary to increase the BP, so we give the phenyl to maintain the BP lah, because we want to make sure the adequate tissue perfusion. But the problem with phenyl, we have to, because when you increase the afterload, at the same time you have the problem with LVOT. So at the point pun you akan decrease the cardiac output. So that
betulkan, phenylephrine adalah alpha agonist.
Alpha agonist.
Dia tak ada beta, dia adalah short acting alpha agonist. It doesn't cause any tachycardia lah. So basically dia akan cause bradycardia, reflex bradycardia kalau you guna phenyl. So why we use phenyl, sebab kita nak temporizing temporizing sebelum kita letak intra-aortic balloon. So itu je lah yang kita boleh buat sebenarnya. Okay.
Kita ada phenylephrine kita ada dekat ED kan?
Kita ada yang undiluted punya, so kena dilute. So tak silap I, satu vial kena dilute dalam 100cc of normal saline baru you boleh guna. So dia punya dia tu bukan infusion, dia guna as bolus punya dose lah, macam kita guna kat OT tu. Okay. So kita bagi dan kita memang plan untuk intra-aortic balloon pump lah. So kalau tak ada, then transfer to center yang ada lah, macam IJN atau something like that. So although you cakap dia good prognosis, tapi 8% tak silap dia punya mortality kan. So and you cannot correct because nombor 2 dia punya problem adalah NORAD punya problem. So because of that, that's why ada role of beta blocker. So when you have this kind of condition, so the best is to just do supportive lah. So kalau you bagi alpha agonist lagi, you bagi NORAD lagi, so basically it will cause more and more increase mortality sebenarnya. So the best is to treat the cause lah. The cause bagi beta blocker. Tapi kalau you tahu beta blocker is not suitable kalau patient ada patient ni ada shock. Number 2, you can support using the intra-aortic balloon lah. That's why ada use of intra-aortic balloon dia untuk reduce the afterload. So if you reduce the afterload, the heart will be contracting more and more efficiently lah. With every pass, dia punya balloon tu akan inflate, so causing the punya aortic volume tu akan kurang, causing more and more blood untuk to be pumped more towards the aorta. Faham tak? Itulah prinsipal intra-aortic balloon pump. So kalau tak ada, then itulah final dan transfer lah. So untuk patient ni dengan burn, so fluid management adalah penting jugalah. So kena bagi partner punya fluid as mentioned lah. In this patient ada heart failure symptom tak ada? Ada.
Dia datang acute onset chest pain tapi tak ada failure lagi. Patient.
Okay, so kalau tak ada failure, so careful fluid resusc lah untuk increase dia punya preload.
Any question from others than Ikram or Daniel want to ask anymore? Before we ask you all with 20 questions.
Hello.
Hello ya.
Nak tanya sikit, kalau contoh patient macam ni, tapi dia bukan datang burn patient lah.
Okay.
Tapi miss, dia datang with the ST elevation semua, with critical chest pain. Then we miss the Takotsubo and masa tu not office hour time. Then we thrombolize the patient.
So what is the
Macam mana? Sorry?
Maksud soalannya
apa soalan Faizah sebenarnya? Kalau kita thrombolize patient Takotsubo apa jadi?
Yes.
Apa jadi? Make it.
Because kalau kita tengok ikut dia punya approach pun when patient come, because the diagnostic to Takotsubo is per se is by echocardiography ataupun ventricular cardiography with clearance of the PCI, means no evidence of obstruction by the PCI. So means at the approach pun when you fulfill the MI with suspicion of MI, so you have to thrombolize because there are few patient still having from the MI, there are few patient will lead to Takotsubo as a complicated as a presentation part. So maksudnya kalau you thrombolize, you can save this patient have the total occlusion true occlusion. Tapi kalau you tak thrombolize, you can miss the patient who actually memang ada occlusion. So the emphasize is patient suspected MI, you thrombolize first. Either ataupun you PCI lah kalau PCI available. If not available, you thrombolize. Tapi at the same time you have to look beyond of that lah, maksudnya highly suspicious lah. Maybe because patient come yang the most common kalau contohnya dia datang dengan syncope because having the episode of sudden bad news, maybe the family death, so patient come with chest pain or come with the syncope. So at the same time you have to approach looking for any possible of the Takotsubo at the same time lah. Tapi if you cannot rule out, it's better to thrombolize lah when the ECG is suggestive ataupun fit the criteria for MI lah.
Okay, kena tengok jugalah apa pathophysiology Takotsubo. Okay, so in MI, okay, in STEMI, that's why kita kena have to be careful lah. So basically, kalau you thrombolize this patient without any obstruction, what will happen is the complication lah. So untung you 30% tak ada 70% tak ada complication. Rugi you kalau 30% ada complication, the patient dapat complication lah. Patient dapat bleeding apa semua. So basically kalau you that's why it is an important thing to notice the history first kan. History of emotion, history of stress, history of apa-apa ni. Then why this patient came, ECG finding, then proceed with echo. Kalau you nampak that Takotsubo punya features, then you might be careful, then proceed dengan PCI. Don't proceed dengan thrombolysis. Proceed with PCI. Any suspicion, proceed with PCI. So sebab you tak nak the complication of bleeding apa semua tu, kan? You nak treat the patient. But if you proceed juga, then dia dapat complication lah. Itu je lah jawapannya.
Okay. Cara jawab Waiva untuk part tu macam Dr. Syed jawab lah, selamat
kan. Kalau you gang ho thrombolyze je, then what will happen, patient akan mati lah ataupun dapat deformity or something like that, ICB So kita nak tu dah lah patient ni ada emotional stress apa semua, then you lagi causing more and more stress lah. So I think the best is to be proficient in echo lah. So untuk mengelakkan benda ni berlaku, so kita kena cegah lah. So gunakan echo, tengok balik, check the proper history, ada tak isi of stress ke apa ke, lebih-lebih lagi kat perempuan lah. So basically this one tengok peak umur dia. Perempuan umur 50 hingga 70, this age group yang lagi banyak dapat Takotsubo. Lebih-lebih lagi kat perempuan Asian dengan perempuan yang ada white kan. So yang bangsa-bangsa lain tak ada. So kena tengok. So prevention is better than cure lah. You tak boleh nak kata, oh I tak tahu dia apa. So kalau you kata tak tahu, then leave it lah, patient akan dapat apa complication. So the ST won't change. Patient akan condition will remain the same. The pain will be there because of patient LV function is impact. So sometimes they will progress to your complication ni lah. Boleh menjawab tak Faizal?
Boleh. Okay, faham.
So to detect it earlier is better than to say that, oh I tak tahu pun. So kalau tak tahu, then have to accept lah the complication macam tu.
Thank you Dr. Syed. Any question?
Ada role tak untuk since patient is stress, ada role untuk glucocorticoid tak? Stress hormone mediator.
Corticoid. Because the glucocorticoid kalau
itu lagi stress ke saya?
Yes. Tapi kena tahulah, so basically this is a trick question. Patient is already in stress, the glucocorticoid is already high kan. So there's no role actually untuk glucocorticoid in this patient.
Tapi kenapa soalan tu macam tu, dia kononnya trick ke apa?
Yelah sebab kata stress condition. Stress in sepsis you bagi glucocorticoid, but stress in this why you don't give, macam tu lah. So sebab patient already had no problem with the hormone problem. So this patient is more towards your punya NORAD kan, banyak noradrenaline. So causing
yang glucocorticoid sepsis tu sebab nak suppress dia punya immunity sikit kan.
Itu hyperimmune kan. So that's why kita
lain lah.
Okay. Any other question? Zaim, aku dah jawab soalan kau pasal cardiogenic shock dekat chat.
Kalau tak ada question, everyone can ready for Kahoot.
Hadiah ada.
Hadiah ada 1 sampai tempat ke 3 berupa e-wallet.
Berapa ringgit nak kip?
Berapa ringgit nanti akan diumumkan lah selepas pemenangan menang.
Tak, aku tak boleh main sebab aku driving. Syed, tolong main untuk aku boleh tak, Syed?
Okay, ready ya?
Commission dah separuh.
Aku dah tahu jawapan, tak boleh.
Macam mana? Share dulu ke?
Share screen.
Tadi main tadi. Kau main. Aku dah jawapan dah. Dia dah menang lah.
Okay, semua dah buka phone eh?
Tak dapat buat ni. Tak boleh main ke?
Tak main.
Okay, dah ada game pin, masukkan pin number tu 644146.
Betul dapat dia kan.
Bagi diri sendiri.
Minta download app Kahoot ataupun gunakan kahoot.it ni dan tulis PIN number. Kalau 3 orang je masuk nanti apa? Menanglah semua orang.
Apa pilih?
644 146.
Siapa yang tak buat apa? Tak tahu pasal slide ni, Nakib tahu tak pasal soalan ni?
Tak tahu.
Tak tahu, tapi present lah.
So boleh main lah, Dimas sikit duit. Confirm menang ke? Tengok perfect ya.
30% dalam tangan dah.
Buat 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Oh, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11.
15 ada lagi.
14. Okay, cukup 15 kita start lah.
Seorang lagi. Tak ada? Okey dah.
Okey.
Boleh start
Soalannya kat situ kan?
Okay, next question. Nanti we'll go at the end of this, we'll have another session to go through all the answers lah. Sekejap sangat ke tak sempat jawab semua orang?
Fokus dulu. Oh, so pemain nombor 1.
Untitled syndrome.
Tak tahu ya.
Salah penentu lah. Kriteria yang diserati. Siapa ni worker semua ni? Suspicious ke? Yang COVID dah naik. Kisah dia. Jadi orang lain nak hadiah kan, dia masuk hadiah kan. Buat apa dia ni? Kalau
Ni panjang ni.
Oh salah. Tak sini tak kisah. Memang tak boleh.
Tak kisah
kalau semi stroke dia. Betul. Satu salah. Salah. Semua salah. Salah. Itu soalan salah.
seterusnya, tak wajib. Apa tadi? Apa kira tadi? Macam gempak sikit dia kan. Kecil tu sampai 3 jam. Kuning. Jadi jangan cakap kan. Jadi jangan cakap. Jangan minta akal ni. Personally dan MID apa bagi kita saja.
Okay, last one.
Ini kau bisa on kita pakai slide kan? Oh, kita semua satu lah.
Okay, 775 L apple dengan
aku baru bagi hadiah.
Nampak 4146 power.
Siapa 416? All three yang menang ni boleh contact Adib for hadiah.
Komen siapa kena mengaku
Tapi
dulu.
tapi must let us know lah who are these people. So who is 644146?
Tak mengaku, Nakib mengaku dia.
Kita aku setuju.
Siapa? 644146?
Adik kau kan strawberry.
Tak ada, tak mengaku, tak ada hadiah.
Strawberry nombor apa tadi?
Okay, boleh. Saya tak faham lah soalan tu, boleh tak terangkan balik kembali apa yang disoal tadi? Safina.
Ya. Mana tadi? Okay, so question 1, which of the following is not an ECG feature of Lbbb? The answer is the last one lah, presence of Q wave. Sebab in Lbbb, the septal depolarization is from the right to left instead of the usual left to right. So in the lateral leads, you will lose your Q wave. Okay. Second question, which of the following is not part of the modified Scabosa criteria? The answer is the last one lah. So excessively discordant ST elevation more than 5 mm is in the original Scabosa. The modified Scabosa is based on the ratio of the ST elevation and the S wave. The concordant part is the same lah for both criteria. Third question, which of the following is not a component of left bundle branch? This one is a third one lah, post-divisional. There's no post-divisional, there's a pre-divisional segment. Yang left posterior, left anterior dengan septal vesicle tu ada. Fourth question, which of the following is not true regarding left anterior vesicular block? The answer is A lah, because left anterior vesicular block will cause left axis deviation. The bottom three statements too all are true. Number 5, which of the following does not typically cause left bundle branch block? The answer is inferior MI lah. Left bundle branch block will usually be seen in anterior MI lah because of the left AD occlusion, which affects your left bundle branch. In inferior MI, you will have ischemia to the AV node, so patient will often have second or third degree AV block. Number 6, which of the following is not a diagnostic criteria for Takotsubo? So based on the there's 4 criteria and you need to fulfill all 4 lah. B is the wrong answers, but they go beyond a single epicardial vascular distribution. So that's why your PCI will be negative lah. Number 7, which is contraindicated in patient with Takotsubo who is hypotensive with evidence of LVOT obstruction? The answer is inotropic agent lah, because inotropic agent can worsen the degree of LVOT. The others are true. Number 8, in comparison to a patient with MI, patient with Takotsubo Cardiomyopathy, the answer is B lah. They will cardiac PCI will be normal for them. Number 9, Takotsubo Cardiomyopathy has a higher incidence rate in Asian. They're more common in females, usually those with physical trigger rather than emotional trigger, and usually postmenopausal women. Number 10, different types of Takotsubo cardiomyopathy may result from transient LV dysfunction at. So you've got your apex, your mid-ventricular, your basal, and your focal hypokinesia. Number 11, which is considered diagnostic for STEMI. So STEMI, you need 2 ST elevation in at least 2 consecutive leads, at least 1 millimeter. But if in V2 or V3, then it needs to depend on the patient's age and the gender lah. So the answer is D. You need 1.5 in female for V2 and V3. Number 12, when is fibrinolytic therapy not indicated? So we kept back on the contraindication. Absolute will be if there's any history of ICB, if the history of ischemic stroke within the past 3 months. Relative contraindication is for the BP more than 180 over 110, or if the ischemic stroke is more than 3 months lah. Then the option C is just a posterior MI lah. Number 13, which of the following is a common cause of chest pain? Is not a common cause of chest pain. The answer is endocarditis. The other 3 are quite common. 14, which of the following is not true? The answer is D lah. Yes, it remains elevated for quite some time, up to 2 weeks, but you need the trend of it, not one single value. So you take two different samples at 4 to 6 hours apart, then it will help in the diagnosis of infarction. Sorry. Number 13, number 15, Which of the following statement is not true regarding reinfarction? The answer is B lah. Streptokinase is a relative contraindication if has been used within the past 5 days or 1 year, not up to 2 years lah. So the answer is B. Number 16, which of the following is not an ECG feature of acute pericarditis? So the answer is C, sebab the PR segment depression in acute pericarditis is in your precordial leads. Number 17, which of the following is not a criteria to diagnose acute pericarditis? You don't need fever, but you need to have a characteristic chest pain. You need to fulfill at least 2 out of the 4 criteria mentioned lah. Number 18, which is a feature of ECG changes in LV aneurysm? The answer is D. T-wave to QRS ratio is less than 0.36 in all precordial limbs. Number 19, which is true regarding stent thrombosis? The answer is C lah. Reperfusion from stent thrombosis is less likely than if the thrombolysis is if the reperfusion is for MI due to native artery or plaque rupture.
Previous slide.
Previous slide 18.
So kalau tengok ayat ni, dia kalau any precordial lead, maksudnya kalau satu pun dia dah rule out kan. Dia dah rule out STEMI. Kalau semua, basically you kena rule out semua baru you boleh cakap oh ni LV aneurysm. Faham tak? Bukan satu lead saja you cakap oh ni less than 0.36 satu lead, then you cakap dia LV aneurysm. Tidak. So semua lead less than 0.36 barulah dia LV aneurysm. Okay?
Okay. So last one, which is not true regarding ventricular septal rupture. IV nitrate is not contraindicated in this patient, in hemodynamic unstable patients, but you need the nitrate to vasodilate, that's to improve to reduce the afterload. If BP low, then you may consider inotropic support, but then again that will ada effect juga lah, because it may vasoconstrict and make the condition a bit worsen. So be cautious lah. That's all. Other questions?
Just share code.
Okay.
Okay, now I will share the QR code for MACPD.
MACPD ke MMACPD?
MACPD. Sekejap For those yang pemenang tadi, kita dah dapat nama untuk tempat kedua, tempat ketiga. Cuma tempat pertama rasanya masih malu-malu lagi untuk rendah diri. Kalau tu saya boleh claim lah saya menang. Nanti boleh PM.
Dr. Faizal.
Boleh nampak ke?
Pukul 12 kita habiskan meeting kita.
Okay. Kalau tak ada apa-apa lagi, semua boleh scan. Nanti kalau siapa yang tak sempat scan nanti saya boleh share akan dalam grup ni lah, grup latest roster yang Dr. Syed dah tak ada lah.
Okay, thank you semua.
Thank you semua. Okay, untuk untuk next week nanti boleh join the track A. Kalau Daniel Ikram nak join track yang sama ni pun boleh dialu-alukan untuk memuliakan majlis.
Nak main kahut. Dapat main kahut tadi.
Oh, dah tahu jawapan.
Thank you.
Okay, terima kasih semua. Minta maaf atas kekurangan teknikal pagi tadi. Terima kasih kepada Dr. Syed. Okay, jumpa untuk next week untuk kumpulan lain yang you all boleh masuk track A. Okay, Assalamualaikum warahmatullahi wabarakatuh.